Welcome back and thank you for staying with us for the last session of this program. This goes to show how enthusiastic you are about acquiring new knowledge on neonatal medicine. The last agenda for today will discuss on cardiology on neonates, and the speakers for this particular session are all from the Children's National Hospital. A great fun fact about this prestigious institution is that it has been ranked number one in new care by the US News, and it's also the top 10 spot for the best children's hospital annual rankings in the United States. What a remarkable achievement. Now, moderating this session, and a very exciting session indeed, is Dr. Syed Ali Raza. He's a consultant neonatologist at Sheikh Shakwood Medical City. He worked for about 12 years on various positions related to his profession in England and also completed his training in pediatrics and neonatology. He has developed special interest in pediatric cardiology and neonatal mechanical ventilation. He's also part of the core faculty of pediatric residency program. He's a fitting candidate to chair this session. And ladies and gentlemen, without any further ado, I'll give this virtual floor to Dr. Syed. Thank you.
Thank you very much, Mr. Vincent, for the kind introductions. And I'm really very excited to moderate these cardiology sessions. Our first speaker is Dr. Mary Donofrio. She is a medical director, prenatal cardiology program. She's also a co-director, cardiac neurodevelopmental outcome program, advanced imaging cardiologist at Children's National Hospital, Washington, D.C. She has done fellowship programs in pediatric cardiology after completing her residency programs. At the moment, she is a national expert in prenatal cardiology and has published over 90 papers, including the American Heart Association scientific statements on the diagnosis and treatment of fetal cardiac diseases. She is one of the founder and current president of the Fetal Heart Society, and through this, she is contributing actively in teaching and training and research and scientific publication activities. Let's say her welcome to Dr. Mary. She's going to talk on fetal echocardiography delivery planning for the fetus with congenital heart disease. Over to you, Dr. Mary.
Hi, everyone. Thank you to the organizers for having me. It's really wonderful to be here. We're in Washington, D.C., as you heard. What I'm going to be talking about today is fetal echocardiography and how we use it for delivery planning for fetuses with congenital heart disease with an overarching goal to improve outcome. I have nothing to disclose. So my objective will be first to highlight data that's showing that prenatal diagnosis of congenital heart disease does improve outcome. And there are some specific caveats to that, which we're going to discuss. I'll review the transitional circulation and discuss why this is important for the newborn with congenital heart disease. I'll then review some fetal echo findings that we look for that enable prediction of a difficult transition and risk for hemodynamic compromise at delivery for newborns with specific diseases, and then discuss some of the delivery management strategies and protocols that we've put in place at Children's National. So as a fetal cardiologist, my goal, first and foremost, is to improve detection of congenital heart disease in utero, and this is certainly a big challenge for us in the United States. We can't initiate specialized care unless we know the fetus has a problem. But once we do detect congenital heart disease, the goal becomes to improve outcome beyond what our current practice is. There are certainly fetal care options that we don't have time to talk about today, but I think just as important is the management of our patients in the delivery room with specialized transitional care protocols and then planned therapies that we can initiate as cardiologists right in the delivery room. So the big question is, does prenatal diagnosis improve outcome for congenital heart disease? And unfortunately, in the literature, there are several studies that suggest a worse outcome after fetal diagnosis of congenital heart disease. But as you look at them, they're limited by their methodology. Most of the time, the fetal diagnosis group have heart defects that are more severe, and And then oftentimes terminations of pregnancy are counted as death. In the postnatal diagnosis group, it is really hard to identify those deaths that occur in local delivery hospitals or even at home. This is a nice study that's now came out a while ago that was a meta-analysis of multiple studies of over 1,300 patients, 22% prenatally diagnosed. And just like all the other studies on first assessment, the mortality was higher in the prenatal group. But the authors acknowledged that the fetal patient data included higher risk diagnoses as well as terminations. And what I thought was interesting was that the fetal diagnosis did not assure optimal postnatal care. So then on a second look, that included only patients with standard risk and intent to treat. And then what they defined as optimal delivery room care, the mortality was in fact lower in the prenatal diagnosis group. If you look at the odds ratio for the individual studies, as well as the overall meta-analysis, there was an improved outcome in those prenatally diagnosed. So this leads me to then come to the conclusion that it's not just the diagnosis of congenital heart disease, but then what we do after, the management, that's important for outcome. So what do we need to think about as we go from fetus to the postnatal circulation, and what are the postnatal considerations for transition in the delivery room? Well, first and foremost, there needs to be an initiation of respiration and ventilation. The airway has to be patent, the lungs need to expand, and obviously this is what our neonatology colleagues are specialists at. Any abnormality of the airway certainly would cause trouble in the delivery room. But just as important are changes in the circulation and the hemodynamics that come with being born. First, there's closure of the fetal shunt pathways, the ductus venosus, the ductus arteriosus, and then the foramen ovale actually closes right in the delivery room. There's a shift in the right and left cardiac outputs from a circulation that we say is in parallel to a circulation in series. There's an increase in systemic vascular resistance that comes immediately with clamping the cord. And there should be a decrease in the pulmonary vascular resistance with initiation of respiration. So if that transition in any way affects the heart defect, or if the heart defect affects the transition, then we at least have to think about specialized care in the delivery room. So who needs specialized care? And this is something that I've been thinking about for a lot of years. When I got to Children's in 2004 and realized we didn't have a delivery room on site, I really wanted to think about what could I do as a fetal cardiologist to identify those babies who would struggle in the delivery room. And what we did was put together a transitional care risk for delivery room level of care. And we use this prospectively and have several reports in the literature showing that it really does work. It has become part of the fetal cardiology guidelines through the American Heart Association that were published in 2014. So looking at it, there are 4 levels of care for us. Honestly, in some institutions that have a delivery room and a neonatology unit right together, 3 and 4 can kind of go together. Level 1 are the low-risk patients that we really expect no instability. Most of these patients can go home and be seen as outpatients, get their surgery later. Level 2 are the medium-risk patients that will need an operation before they go home, but we do not expect instability in the delivery room, and this is mostly the ductal-dependent lesions. And then the 3s and 4s, the high and the really high-risk patients, are those that will have significant compromise right with cord clamping. When we think about improving outcome, certainly with delivery room management changes, what we're really looking at are these very few number of patients, but the sickest patients in the highest risk category. So let's just go through a couple of examples. First, the left to right shunt lesions. These are ASDs, VSDs, and even some more complicated defects like AV septal defects, AV canal defects, here where you can see the 4 chambers of the heart, the big hole right here in the middle with a single common AV valve. And then the color really shows that there's no flow going across these holes in the heart. And so these patients will actually be very well in the delivery room and actually for weeks after birth because the shunting doesn't happen until the pulmonary resistance falls, which can take weeks. So these patients usually can go home and then be seen as an outpatient. Another diagnosis that falls into this category is a little bit more complicated, truncus arteriosus, where here you can see the normal 4 chambers But in this picture here, a single artery that gives rise to the aorta and the pulmonary artery. And then down here, the single outlet, which is the truncus. This is actually a lesion that does depend on shunting. And again, stable in the delivery room and maybe even in the first week of life. So these are what we call our low risk or level 1 diagnoses. Cardiology, most common cyanotic congenital heart disease. We all know 4 things. 3 of them are present in the fetus. First off, as we start to look, the 4-chamber view is normal. This is why sometimes obstetricians don't see this diagnosis in utero. But just by angling a little bit superior, you can start to see a big hole in the heart. And then a little bit further, this is the aorta that overrides the interventricular septum. And a little bit further superior, we can see the pulmonary outflow tract. And this here is the pulmonary valve, which doesn't look normal. So there's pulmonary stenosis. We all know there are pink tents and blue tents. Pink means the oxygen level is okay and they can be repaired electively. Blue is a ductal-dependent pulmonary blood flow lesion. So how can we decide whether this baby is low risk or medium risk, needing prostaglandin and transfer for an operation? There's several studies in the literature that tell us as fetal cardiologists what to look for. We can look at the size of the valve. But more importantly, actually, what we found is looking at the ductal flow pattern. In the fetus, the ductus should flow away from the lungs, so right to left. And if we see that reversed flow pattern, which is this little red jet, the left to right shunt into the pulmonary artery, this suggests that the pulmonary outflow is inadequate. So suddenly just this little red jet tells me that this is a ductal dependent lesion. We're going to need a neonatologist to put a line in and start some prostaglandin, and this baby's going to need surgery. So now let's just move on to the high-risk diagnoses. Thank goodness there aren't a lot of them, but these can be the sickest kids right from the time of birth. Here's the list from our work in the first paper that we published in 2013. We can identify which of these subgroups of patients with these specific defects will be sick and be assigned a higher risk diagnoses. And most importantly is the care plan that we put in place once we decide or identify that these patients are likely to get sick in the delivery room. So let's look at some examples. This is hypoplastic left heart syndrome. This is pretty easy to see. The left side of the heart is missing. This should be the left ventricle. The mitral valve is atretic. But what makes this one ductal dependent is actually this is the aorta, this little tiny 1 millimeter blood vessel. And flow is going away from the spine, so reverse flow in the transverse arch from the ductus arteriosus. So this is a ductal dependent lesion. Obviously, this one needs prostaglandin and transfer, so this is automatically a medium risk patient. But in about 10% of babies with hypoplastic left heart syndrome, there's an additional restrictive or intact foramen ovale that can potentially even get worse at the time of birth. And so now when we go back and try to look at the atrial septum, it's actually really hard to tell if there's flow going across or will that connection be adequate. So is this a medium or high risk patient? Those hypoplastic lefts with an intact atrial septum get sick very fast. Just as soon as ventilation starts, there's blood that goes into the lungs and then it can't get out. So you have rapid pulmonary edema. And unless you do something pretty quickly, you're going to get sick, acidotic, and hypoxic very quickly. So the literature tells us to look towards the pulmonary vein flow, which are representative of left atrial pressure in the fetus. And it's this pattern here in the bottom that suggests that baby's going to be in trouble. So this baby did have that pattern. And so this is one of our high-risk diagnoses. So what do we do for this at Children's National? The delivery room care. First off, easy, start prostaglandin. Our stabilization strategy is to really take total control of the circulation and to try to maximize oxygenation with intubation, sedation, and then paralysis right in the delivery room. Oxygen is used sparingly. We use it to keep the O2 saturation in the preductal, so in the arm, somewhere around 70 or 75% if possible. But really what needs, and then we have ECMO backup, the ones that have an intact atrial septum can get very sick very quickly. Ultimately, we prepare for the cath lab to happen as quickly as possible, and we go from the delivery room to the cath lab straight away. Here is a picture of a postnatal atrial septum intact. You can see in this cartoon why, if this was intact, why that blood just couldn't make it back to the circulation, why this kid would get so sick very fast. We use echo-guided and fluoroscopy-guided intervention. This is a very specialized blade catheter that can be put across the atrial septum to improve that connection. And then post-procedure, you have a relief of that pulmonary venous obstruction. Next one on the list that's a terrible disease is Epstein's anomaly. It's an anomaly of the tricuspid valve. This tricuspid valve is very dysplastic. The septal leaflet is stuck. Heart is huge compared to the chest. And the blood's really just swirling around in here, so it's not getting to where it needs to go. In a multi-center study that we participated in that originated in Boston that was led by Dr. Freud, mortality in the current era was 45% overall, with a significant in utero death of 17%. Predictors of mortality were early diagnosis, a big tricuspid valve, the presence of effusions or early hydrops, and the presence of pulmonary insufficiency. And non-survivors had low birth weight and early gestational age at delivery, usually because they were hydropic, and then pulmonary insufficiency at any gestation. So that's an important marker for us to look at. So here now, looking at in this particular patient of this pulmonary outflow, there is no forward flow. This red represents significant pulmonary insufficiency. So this certainly is a high-risk patient. So what do we do for these kids? Well, it's up to us in the fetal cardiology world to try to decide if the pulmonary valve is atretic or just not opening. If it does open and there's pulmonary insufficiency, this is what is called the circular shunt, which is backwards flow across that pulmonary valve, backwards flow across the tricuspid valve, and the blood just kind of gets stuck in this path, doesn't make it to the body. So in this instance, we think the ductus is at least partially the problem, so no prostaglandin is initiated, versus those that have true pulmonary atresia, we do start prostaglandin in the delivery room. The specialized strategies for ventilation certainly, again, include getting total control of ventilation to maximize oxygen delivery, intubating, sedating, and paralyzing. And we want to try to decrease the pulmonary resistance if that pulmonary valve is open, in, at least in the delivery room, until we get to the ICU, where then a reassessment is made. We use 100% oxygen and then consider using nitric oxide in the delivery room, again, to rapidly help that baby transition. ECMO is used for this as backup as well until we can figure out what surgical procedure is needed. Another one that causes trouble in the delivery room is tetralogy with absent pulmonary valve. On the inside, it's a tetralogy with a big hole in the heart and an overriding aorta. But as you angle up towards the pulmonary outflow tract, it's not a thick, small pulmonary valve, but actually a dilated annulus with a valve that's really not opening or closing, and then really massively dilated branch pulmonary arteries that affect the lungs. There's not usually a ductus in this disease, which is interesting. And then obviously the biggest problem is significant pulmonary insufficiency, which is this red jet here. So the mortality in this group, looking at multiple studies in the literature, is pretty high, between 40 and 70%. But what's really interesting is that there are two very distinct subgroups that get reported time and time again in multiple different papers. About half of these patients have no respiratory symptoms in the delivery room and actually are straightforward tetralogy patients that can be repaired electively. And then the other half have significant respiratory compromise with CO2 retention and acidosis and hypoxia right in the delivery room. And we think it's obviously due to multiple factors, but tracheobronchial malacia and lung hypoplasia or hyperexpansion, congenital lobar emphysema with air trapping. The mortality in the literature, single center studies, eye drops, any right or left ventricular dysfunction, if there's an associated genetic abnormality, this is often associated with microdeletion on chromosome 22. But interestingly, it's not the size of the branch pulmonary arteries in these single center studies. And so it's not a direct correlate of the big pulmonary arteries are pushing on the tracheobronchial tree. However, if you have respiratory symptoms at birth, you're more likely to die. And so then our challenge as the fetal cardiologist is to try to predict which one of those babies are going to have respiratory symptoms. So we took this challenge on at Children's National, and this is one of my fellows put together a multi-center study that was published this year. 19 centers. We had 78 patients with an intent to treat, so that took out the terminations. 71 of those survived to birth, so a 9% in utero mortality. And again, that 50-50 rule sort of held up with 53% having an elective repair with an overall good survival. And then the other half either died without intervention or surgery because they were just so sick. 30% of them required emergency surgery to try to open up that outflow tract to take the pressure off the lungs, with a 71% survival. Echo predictors of death included a big heart, moderate or severe right-sided dilation, any left-sided dilation, RV or LV dysfunction, and a large pulmonary valve Z-score, which really is a correlate for the amount of pulmonary insufficiency. Interestingly, we as well found that the size of the branch pulmonary arteries didn't matter. And we did try to look at lung findings that you would see on fetal echo. So it's really how the lung affects the heart. Mediastinal shift and left or right lung enlargement or compression were in fact associated with poor outcome. So now we take this same patient and we kind of ignore the heart and try to look at the lungs. It's a little bit of a challenge on ultrasound. Maybe this lung is a little bit brighter than this lung. This lung looks bigger. Is this lung smashed or is it hypoplastic? So for this particular patient, we used fetal MRI. And the only surprise was how easy it was to see that the lung was really abnormal. So here you can see a massively dilated right lung that's full of fluid. The left lung is the sliver back here. The heart is the black in the middle here. And you can see this big right lung, hypoplastic left lung, and we were even able to see deviation of the trachea on this study. So this fluid-filled lung will become an air-filled lung with air trapping and CLE. What we anticipated. So certainly this is a high-risk diagnosis. That's exactly what happened. This kid deteriorated rapidly and had to be cannulated onto ECMO. We had it ready to go right in the delivery room. So what do we do for these kids? First off, you can try prone position for the ones that aren't quite so severe. Sometimes pulling the pulmonary arteries off the airway can help. But the ones that we really expect to be sick, again, intubate, sedate, and paralyze to control that ventilation. The goal is to minimize air trapping. The last thing you want to do is blow a pneumo in addition to the other things that are going on. You want to try to decrease pulmonary resistance, again, oxygen and nitric oxide, and we always have ECMO backup for these. Transposition, this one's my favorite. This is the only leftover diagnoses where the pre-op mortality and morbidity is higher than post-op. And it's really the foramen and the ductus that contributes to the problem. The literature, single center studies tell us what to look for the atrial septum and the ductus. This is a restrictive foramen with a tethered septum primum. The blood is just swirling around here on the fetal picture. This is what we call a hypermobile atrial septum. It's flipping back and forth. That's due to elevated left atrial pressure in utero. And here, the aortic and ductal arch. This ductal arch measures small. And then flow in the ductus should be only in one direction, but we can see that it's bidirectional. So certainly all these findings suggest that this baby's going to be sick in the delivery room, require a septostomy. These are high-risk patients. But the trick with and the difficulty with transposition is that if you see these features, it's very specific for difficulty in the delivery room. But unfortunately, if you do not see these features, you have about a 50-50 chance that the baby will be sick. So those aren't very good odds. This is an example of a case that I reported a long time ago now as a young attending. showed up in my office at 34 weeks. Actually, in the OB's office, there was fetal distress with abnormal, horrible-looking heart rate tracing. And as they were prepping for a C-section, we took a quick look. The heart's dilated, the foramen is intact, and the ductus is gone. So this is transposition with the closed foramen and ductus. That results in a very sick fetus and a very sick newborn for sure. This is a really, really high-risk patient. We had ECMO in the delivery room for the section. There was cardiac arrest, right, with cord clamping. We were able to cannulate onto ECMO, and this kid did go on for an arterial switch operation, but unfortunately died from complications relating to pulmonary hypertension. Now, looking at, so what do we do for these patients? Well, it's obviously ductal dependent, prostaglandin, that's the easy part. Stabilization strategy, 100% oxygen, certainly is useful. You want those saturations to be as high as possible in the preductal area. You want PVR to fall. If they are very hypoxic and we're worried that the septum is closed, we actually do an echocardiogram in the DR. We'll intubate, sedate, and paralyze. And if there's reverse differential cyanosis with marked hypoxia in the preductal area, so saturations on pulse ox of less than 60, we will start nitric in the DR. Again, reassessment once the kid gets to the cardiac unit once we've changed the circulation. Plan for the balloon septostomy. It can actually happen in the DR, in the ICU, or in the cath lab because we can do balloons using echo guidance. So here's an intact atrial septum with just a tiny connection down here. Pay attention to the balloon that's in the left atrium. It's accessed via the femoral vein. Push the balloon down across the foramen, blow it up, and then pull it across, and then an open atrial connection. Total veins, not much to say. There's multiple kinds. If you want to know where the pulmonary veins insert into the systemic circulation, but the important part for the delivery room is, are these veins obstructed or not? And so can we figure that out on fetal? This is a heterotaxy patient with a single ventricle, but if you look, this little red thing is the pulmonary vein trying to get to the heart. It doesn't quite make it. It goes down below the diaphragm and circles around to enter the portal system. Usually the infradiaphragmatic veins are obstructed, but that's not always true, and supracardiac veins can be obstructed as well. So is this a lower high-risk patient? Again, we use flow patterns. This report from a single center tells us to look for this, and that's exactly what we found. So this is high risk. There's not much medically that you can do for these patients. These patients need surgery. So whether you decide to cannulate onto ECMO or to go straight to surgery is center dependent. Fetal arrhythmias, the tachycardias can be primary arrhythmias leading to secondary heart failure or primary heart failure from cardiomyopathies leading to secondary arrhythmias. Either way, tachycardia and hydrops. You can see the fluid in the abdomen and around the lungs. That's a bad sign for an increased risk for death, both prenatally and post-delivery. The bradycardias, in particular, AV block, can be related to SSA, which is the connective tissue lupus or Sjogren's. It can be associated with endocardial fibroelastosis, so scarring of the myocardium, which leads to heart failure. You can also have very severe congenital heart disease with heterotaxia and left atrial isomerism that can cause a cardiomyopathy. You can see how thick the heart is, and AV block. Factors that influence outcome is if you're forced to diagnose to deliver these babies early, because they're hydropic, the outcome is poor. Certainly if there's associated congenital heart disease, you can't control the rhythm in utero, either it's too fast or too slow, that certainly influences the outcome. And as I said, hydrops and the need for a premature delivery. So these patients certainly will be sick in the delivery room, and there needs to be a strategy put in place to somehow deal with the rhythm, whether it's cardioverting or using medications for the fast rhythm, speeding up the slow rhythms with beta agonists like epinephrine or isoprel, or even pacing in some instances. So back to my study, can we predict delivery room care? This is 8 years worth of experience. We had over 8,000 fetuses. 7,400 were normal. We do a lot of screening. Were we good at our screening? We only missed 4. So it was a less than 0.01% miss rate. 3 of the 4 had coarctation. That's a tough thing for us to diagnose in utero. More importantly, the ones that we assigned a level of risk, whether it be 1, 2, 3, or 4, how do we do with that? The level 2s are important because those are the ones where I say, you can deliver where a neonatologist is present, but the cardiologist does not have to be present. In this group, we had 260. There were 7 that we missed, and these all were transpositions. So this early in the experience where we assign these levels of care, we tried to use the parameters that we saw in utero to predict foramen closure. One of them got very sick, and it only took that one patient for us to realize that you just really can't trust what's going to happen in the delivery room for transposition. So no matter what the fetal study shows, you have to be prepared to intervene and open the atrial septum. For the 3s and 4s, we were pretty much on target with what they were needed. This all got put together in the HA scientific statement, the lesions, what to look for on fetal, and then what to do about it in the delivery room. And again, the expert consensus was that all fetuses with transposition should be considered at risk. So can we do any better? What we're doing now is called hyperoxia testing. So if you give a mom 100% oxygen in the 3rd trimester, you will actually decrease the fetal pulmonary resistance and increase pulmonary blood flow. And this simulates sort of what's going to happen in the delivery room. This is our proof of concept publication that says that we did find it useful for Epstein's to say, will that pulmonary valve open? For the total veins, is that vertical vein going to be restrictive or obstructed? How about the egress from the left atrium and hypoplastic left heart? And then in transposition, gives us some idea on the foramen and the pulmonary resistance. So here's an example. This is a transposition fetus that the red shows open foramen ovale flow, and then with just 10 minutes of oxygen, the foramen closed. So this certainly was a fetus that we thought would be at risk for atrial septal closure. Okay, just to finish up with all of our other subspecialists, for the obstetricians, there's no data to support the benefit of a C-section or vaginal delivery with rare exception. Fetal monitoring, there's no data to support any additional monitoring beyond what is typically done for all pregnancies. The delivery timing, however, does matter. Multiple studies, this one from the STS database suggests that the best time to deliver a baby with a significant heart defect is after 39 weeks. This is hot off the press. I'm very proud of this. This is an effort that spanned our disciplines. Dr. Berger, who you're going to hear speak, as well as our neonatology colleagues, Dr. Short's colleagues in neonatology, we all got together to say, how can we standardize our delivery room practice for these very high-risk diagnoses? So obviously, the general approach follows standard neonatology guidelines. You certainly need positive pressure ventilation for apnea or poor respiratory effort. You do need to start chest compressions for significant bradycardia or asystole, unless there's a conduction abnormality that we identify. So if there's AV block with a heart rate of 50, you don't want to start chest compressions. As far as what the targeted oxygen level should be, that's the challenge, and whether to use supplemental oxygen. So we do know there's a transition over the first 10 minutes and what oxygen level should we shoot for or aim for. But there's a big question mark when we're talking about congenital heart disease, and this is where the fetal diagnosis will help us to interpret these oxygen levels on the anticipated diagnosis-specific physiology, and then use supplemental oxygen as needed with aiming for that targeted saturation. We put together this nice summary table that looked at those different diagnoses. Should you intubate? Should you use oxygen? Should you sedate or use neuromuscular blockade? Do you need an echo in the delivery room? How about prostaglandin? What about lines? With a goal being to get out of the delivery room as quickly as possible to where care can be initiated for these high-risk diagnoses. We also put together checklists for specific diagnoses. This is an example of one of them. Usually this checklist is printed and put it right in the resuscitation room. Our transport team carries it. Now for the higher risk diagnoses where the cardiologist as well as other specialists need to be present, we do coordinate delivery room care with flow diagrams. This is from one of our later publications, and create these flow maps really saying where people should be and what their job is at each stage in the resuscitation. So how do we do for these really terrible defects? Again, this is from one of our earlier publications, 34 fetuses with very, very, very severe disease. The gray is what we anticipated needed to happen. We were right pretty much all of the time on what needed to happen. What's important is for these awful diseases, the delivery room survival was 100%, and survival to discharge was 83%. Other things we looked at the time to care and time to the intervention, certainly if we coordinated it, it happened faster, and there was an effect on oxygenation. Looking at other places where there's different resources available, the study that came out of India of 119 with critical heart disease, 33% were prenatally diagnosed. They had a 10% mortality, with 9 of those dying preoperatively. In the prenatally diagnosed group, there was better pre-op hemodynamics and a lower transport risk index of stability. Lower preoperative mortality in the prenatally diagnosed group, meaning that coordination of care to get them to what they needed sort of improved survival. And in the group that were postnatally diagnosed, there were 7 out of those 10 died because of injury to their organs precluding surgery. In another resource utilization, this is Toronto, so big city within kind of a large country where referral is to 2 main centers. 129 diagnosed with ductal-dependent lesions, half were prenatally diagnosed. They were admitted faster if they were prenatally diagnosed, but they had a lower lactate. They were less likely to be ventilated or require vasoactives. They were less likely to arrest before surgery and less likely to die before surgery. So again, the fetal diagnosis allows planning of care starting right in the delivery room. So in summary, the fetal diagnosis of congenital heart disease, I do think improves outcome. We need to understand the circulation and plan for transition in the DR, and certainly a team approach, including cardiology, ICU doctors, neonatology, transport. All of us are needed for a successful outcome. So with that, I will stop. Thank you very much for your attention.
Thank you very much, Dr. Mary, for a very nice and detailed talk on antenatal diagnosis and management. Our next speaker is Dr. John Berger. He is a medical director and pulmonary hypertension program and cardiac ECMO at Children's National Hospital. He is presently front area of practice is pediatric cardiology and pediatric cardiac critical care medicines. He has done his medical school in Washington University and then completed his pediatric residency and neonatology training program, Oregon Health Sciences University, and then pediatric critical care medicine fellowship, pediatric cardiology fellowship at Children's National Hospital. Presently, he is an attending physician in critical care medicine and cardiology at Children's National Hospital since finishing his training. And he was the founding medical director of the Cardiac Intensive Care Program and Pediatric Pulmonary Hypertension Program. He has been an investigator and co-investigator in Pediatric Collaborative Critical Care Research Network. Interests include management of critical care, cardiac disease in children and neonates, advanced heart failure, ECMO, and pediatric pulmonary hypertension. Today, he is going to give us a talk on not just the heart disease in a preterm infant. Over to you, Dr. John, please.
Thank you very much for allowing me to speak today about low birth weight infants and congenital heart disease. I have no relevant financial disclosures. The objectives of my talk today are to discuss the risks low birth weight babies and prematurity pose for neonates with congenital heart disease, and discuss the risks and benefits of delaying cardiac surgery versus going ahead and doing early cardiac surgery shortly after birth. So we've seen in congenital cardiac surgery, since I've started practice, tremendous improvements in mortality rates for children with congenital heart disease. In the current era, in the United States at least, the mortality hovers between 2 and 3%. And importantly, we've seen the drop in mortality for the highest risk categories, patients who are born with problems like hypoplastic left heart syndrome or truncus arteriosus, dropped from over 50% in the early 80s to somewhere around 10 to 20% in the modern era. That improvement in survival is primarily driven by changes in cardiac surgery for older patients and term newborns. If we begin to look at what are the risks for premature infants, the risk of mortality is substantial. This is looking at the creation of the STS database and risk stratification. And the patient factors that the surgical group added were age at less than 1 month or over 1 month and a weight criteria. And if your age is less than 1 month and your weight is less than 2 kilos, your risk of dying goes up by almost a factor of 5. That's shown in the red box. And even if your weight is between 2 and 3 kilos, you still have a substantial increase in mortality. Looking at a single center study in a more modern data set, this is a study looking at 171 low birth weight babies and or premature infants born at less than 37 weeks compared to 342 control babies. And they were matched for diagnosis and procedure and year of operation. It excluded babies with PDA ligation, ECMO, or pacemakers, and the operation had to occur in the first year of life. And in this slide, first of all, the top diagnoses are all children with complex congenital heart disease. These are children that are not going to necessarily get out of the hospital without an operation. 20% had transposition, 10% had arch hyperplasia of one sort or another, 10% hypoplastic left heart syndrome. And if you look by operation or diagnosis, mortality is reduced in almost all cases, whether it's a bypass case or a non-cardiopulmonary bypass case. But as you can see here, even in simple coarctation, there's a 13% mortality versus none in the term infant group. Even a VSD, another operation that should have essentially zero mortality, there was an 8% mortality seen. I like to show this graph because it shows sort of the mortality risk based either on gestational age or weight. And as you get to around 35 weeks or around 2 kilograms, your risk of mortality goes down, or your chances of survival goes up substantially. So that seems to be an inflection point. And this is similar from other data sources, including the STS database. Complications, on the other hand, sort of follow a linear pattern with, as your gestational age goes down, your complication steady rate goes up. Similarly, as your birth weight goes down, your complication rate goes up, including things like ECMO or need for unplanned surgical reinterventions or the development of pylorthoracic. As Mary showed in the last presentation, even 37 weeks is too early. This is a study from the STS database about a decade ago, looked at 4,700 patients. although there were almost 10,000 patients in the database, 48% of those patients were born before 39 weeks. As Mary showed in her talk, being born at less than 39 weeks is associated with an increased odds ratio for mortality that goes up substantially, as well as an increased risk of complications and a longer length of stay. So shooting for 39 weeks is what we aim for. It is complicated by the fact that if you have a complicated neonate or a neonate with complicated congenital heart disease, who's going to need to have a surgical team on standby, a cardiac ICU team, potentially a catheter-based cardiac interventionalist team, special delivery team, neonatology, trying to coordinate and make sure the mom doesn't go into spontaneous labor before 39 weeks, complicates this equation. So why is it so much harder in premature infants? Why is their mortality risk so much higher? Well, first of all, there are technical considerations. Even the simplest operations are going to need a technique known as hypothermic circulatory arrest, and I'll show you why in a second. That is a much more harsh technique in terms of an infant's tolerability of it versus cardiopulmonary bypass. There is difficulty in sizing the shunts and bands that we might use to palliate a small trial. We can only reduce the size of our shunts to a certain level. And our techniques remain in flux. We're not happy with our mortality risks. These patients are with the highest risk groups are rare within a single institution. And so there are things that change over time, and we don't necessarily know whether those changes are going to be good or bad for our patient. And then, of course, there are the patient factors that you all are aware of in terms of the organ immaturity and tissue fragility. Cardiopulmonary bypass is obviously a big stressor to the body. It is sort of what I would characterize as a mini sepsis episode. There's complement activation. There are activations of multiple inflammatory pathways, as well as ischemia reperfusion injury, particularly to the myocardium. And this leads to both endothelial and myocardial dysfunction, as well as potential injury or stress to other organs. But I'd like to show this picture. This is a picture of a VSD closure in a 6-kilo child. And the things that you're seeing on here, here's the ventricular defect in the middle. This is the large hand of the cardiac surgeon. These are forceps. This is a cannula to provide cardioplegia. This is an arterial cannula. This is a venous cannula in the SVC. Behind here is an IVC cannula. This is a left atrial cannula to keep bronchial collaterals from filling the field with blood. Obviously, you can't get all of this in to a baby who weighs 1.6 kilos or 2 kilos even. And so the only way you're going to accomplish this simple operation is to put in a single cannula into the right atrium, single cannula into the aorta, cool the baby down to 14 to 7 degrees Celsius, cool the entire body down, and then stop the cardiopulmonary bypass circuit and remove all of the cannulas to do your operation. This is a technique known as deep hypothermic circulatory arrest. And really can be conceptualized as whole body ischemia at a cold temperature for somewhere between 40 and 60 minutes. And in addition, operating on 1.6 kilo heart, you're going to have a lot more tissue fragility and inability to hold sutures, etc. And it is associated with both long-term and short-term morbidities, things like acute kidney injury in the cardiac intensive care unit during the recovery period, as well as concerns for a higher incidence of seizures. The other big technical consideration is sizing shunts and bands. A typical size shunt, aortopulmonary shunt, for somebody who needs increased pulmonary blood flow for a term newborn is 3.5 millimeters. Will occasionally go down to a shunt of 3 millimeters in diameter. Any smaller than that, the risk of thrombosis goes way up. Similarly, trying to band or reduce pulmonary blood flow with some sort of flow constrictor is also very difficult in smaller babies. So that means that we're likely to overshunt or not reduce the pulmonary blood flow to the lungs in a fashion that's going to allow the baby to grow. And so we're going to give the baby congestive heart failure. And with the congestive heart failure, there'll be poor growth because a lot of the calories that would otherwise be for growth are used to pump blood. Often these babies will end up returning to mechanical ventilation because of decreased lung compliance and pulmonary edema. And with large volume overcirculation, you can induce pulmonary vascular disease. And if we look at contemporary data in the United States, looking at from a critical care sort of data set, the mortality risk for a pulmonary artery or aorta pulmonary shunt in a term infant is 4.5%, with a four-fold increase to 16% in preterm infants. And these are preterm being defined as less than 37 weeks gestation, and not even the small premature infants that we sometimes see. And then there are patient factors, including CNS immaturity, immature lungs, kidneys, a risk for enterocolitis that is independent of your gestational age, and then the long-term consequences of living in a hostile environment. And I would submit that the CICU, in terms of neurodevelopmental care, is a lot more hostile than a NICU is for a large variety of reasons. I'm not going to talk a whole lot about this. I did want to highlight an issue about CNS immaturity, because in congenital heart disease, I really have changed my focus and thought about thinking about congenital heart disease. It's really congenital brain and heart disease. And the reason I've changed my focus is a graph like this. When you look at children who have moderate or severe or complex congenital heart disease, those children who are going to end up in the cardiac ICU for a long period of time, very few, in severe disease, only 30% versus 25% of children will escape through their cardiac palliation course without any neurodevelopmental issue. The large majority of the complex children will have neurodevelopmental issues, and these can be quite subtle. I was reminded of a patient of mine who I just saw in follow-up who had done very well all through high school until last year when he was a senior in high school. And because of virtual learning, he essentially failed his final semester of high school and actually had to go to summer school to complete high school. So very few, and it can be subtle. Why does this happen was both a combination of changes in fetal blood flow. We all know that placental blood is in a fetus with a normal circulation is directed towards the brain. But if you've got a child who has a mixing lesion, such as hypoplastic left heart syndrome, you're going to mix deoxygenated blood from the brain with oxygenated blood from the placenta, lowering the oxygen content and the oxygen delivery to the brain. And in patients with detransposition, it's going to be very blue blood going to the brain. Does that translate to abnormalities? Absolutely. This is a study looking at brain volume as assessed by MRI. And as you can see during the open boxes are children with congenital heart disease. And as you can see in the third trimester, their brain doesn't grow as rapidly as a child without congenital heart disease. That can result in a bigger risk for preoperative brain injury. We also know that brain maturity is delayed in children with severe congenital heart disease. This is looking at an index of brain myelination, again, as assessed by MRI. In this dark gray box, on the left-hand side is children born at term. In the middle box is children born prematurely at 36 to 37 weeks without congenital heart disease. As you can see, their brain myelination is delayed. And then finally, in the white box on the right-hand side are children born at term with congenital heart disease. And their brain myelination is similar to that of a 36-week gestational age infant. So their brain maturation is delayed by approximately a month. And we know that those children will have preoperative lesions. Approximately 1/4 of children with either hypoplastic left heart syndrome or detransposition of the great arteries will have preoperative ischemic lesions. Some of them will have hemorrhagic lesions. And with the consequences of bypass, 3/4 of them will have new or worsening lesions. How does all this immature brain stuff factor into our treatment decision? And it really is a question, for me, is prolonged cyanosis, prolonged congestive heart failure better or worse than an early exposure to cardiopulmonary bypass? And importantly, does early cardiac surgery really shorten ICU stay and shorten lack of neurodevelopmental care, or is it just accompanied by long postoperative stays? And these are questions that are still not clearly answered in the literature or even in our own practice. Let's talk a little bit about treatment strategies and primarily when to operate for cardiac surgery. So this is the paradigm. I mean, it's easy to understand. You want to operate when the probability of mortality or morbidity is lowest. And if we graph age or weight at the bottom, we want to operate where the big red arrow is. But one of the questions is it what or when? Is it a certain gestational age or postnatal age, or is it a certain weight? We'll talk about that in a second. But more importantly, the conundrum is how to get there. How do you get to a certain age or a certain weight with a patient who is an optimal candidate for surgery? If you require 1 month of mechanical ventilation and your patient is anosarchic and has had intracranial hemorrhage by the time you bring them to surgery, or 3 or 4 episodes of necrotizing enterocolitis, I would submit that that is not an optimal candidate for surgery, and that waiting, you may have waited too long. Here's a quick patient example. We have a baby with critical aortic stenosis who's born at 31 weeks, weighing in at 1.2 kilos. The infant is treated with prostaglandins to keep the ductus arteriosus open. It's on day 1 or 2 of life, and the infant looks pretty well. It's got a 90% saturation on room air, not needing any additional respiratory support at the moment. What do you do with this baby? We could medically manage them to allow patient growth and organ maturity before definitive repair. That essentially means in this infant continuing prostaglandin. In the particular example I provided, you could do an aortic balloon valvuloplasty that may be curative or at least definitive for a while if the morphology of the valve is appropriate. But even if the valve isn't appropriate for balloon valvuloplasty, you might get some relief of stenosis long enough to allow the baby to grow and come off of prostaglandin. You could do a definitive complete repair with a valvuloplasty or a surgical valvuloplasty or a neonatal Ross procedure. So these are the options. The data for specific lesions overall is very variable and again remains in flux. What are the different disadvantages? Why operate early versus late? Well, arguing against delay is you have complications of prostaglandins, including apnea and peripheral edema. If the patient is in heart failure, that weight gain that you're trying to see is difficult to achieve because of the abnormal physiology. If they're cyanotic, you're exposing organs to prolonged cyanosis. And then you have all of the ICU-associated morbidities, particularly for access. And access becomes very important in children with congenital heart disease, particularly those children who are going to need multiple operations. So, and particularly those children with single ventricles, because deep venous thromboses can affect their candidacy for subsequent operations. And then there is attrition or mortality prior to the operating room from all of the ICU morbidities that we know well, including sepsis and necrotizing enterocolitis. The argument against early surgery is the technical issues, the immature organ systems, the abnormal chest wall mechanics that are going to occur after you split the sternum or perform a thoracotomy, which may result in long-term mechanical ventilation. And then there is a higher surgical mortality risk. I must say that in my field, there's been a bias, I think, towards early intervention and early surgery. This is just one of the first studies that sort of tried to answer that question. This is a paper looking at the consecutive 100 infants born at less than 2.5 kilos at a single institution. 62 of whom have had early intervention with a mean operation at 9 days with 81% survival to hospital discharge. There was a group of 26 infants who had a late intervention with a cumulative survival to hospital discharge of 69%, with most of the deaths actually occurring before they had intervention and typical ICU sort of issues in terms of necrotizing enterocolitis and sepsis. More modern series looking at, again, a single center study looking at infants having an operation at less than 3 months and less than 2 kilograms. The group that got delayed surgery had an average growth of about 95 grams. There were differences between the groups of children who got delayed versus earlier surgery. The delayed surgery group tended to have right-sided obstructive lesions or right cyanotic heart lesions like Cardiology of flow, while the early surgery group tended to have lesions that obstructed systemic blood flow. The birth weights and the gestational ages were younger in the delayed surgery group. The time to surgery in the delayed group was 2 months. And what was important outcomes for this paper is that the complication rates were much higher in the delayed surgery group as would be expected, but there was no difference in hospital mortality. So that delay might be useful in individual cases, but you may not improve the survival of the patient overall. Looking at the question in a different way about whether you should grow a baby or operate, as opposed to this is a multi-center study looking at a critical care data set, C4, again, a relatively early era. All of the infants in this study had a birth weight of 1.5 kilos at birth, so very small babies. All of the babies had their operation at less than 2.5 kilos, and outcomes were, or the groups were stratified by weight at surgery. Infants weighing less than 1.5 kilos versus 1.5 to 2.5 kilos at surgery. And, the median age at surgery between the two groups was 14 days for 53 days. And the results were interesting. there was no statistical difference in survival overall, or whether you divided the patients into subgroups such as one ventricle versus two ventricle repairs, or those infants requiring cardiopulmonary bypass versus no cardiopulmonary bypass. Additionally, there was no statistical difference based on diagnosis, but the ends are very small, and I think are very telling just looking at the raw number. If we look at patients with hypoplastic left heart syndrome, if you had your operation at less than 1.5 kilos, there were 7 infants with 1 survivor versus a larger infant where the 6 out of 9 infants survived. Similarly for TAPVR, autonomous pulmonary venous return, 1 survivor out of 2 versus 7 out of 9. But I think that, particularly for infants with left-sided obstructive disease, operating at a very, very early age may not be the right thing. And at our own institution here, we've adopted a strategy for these very small babies, in particular for hypoplastic left heart syndrome, that is not a definitive repair. We perform bilateral pulmonary artery banding and then continue the babies on prostaglandin and either then do a delayed Norwood procedure, which is an arch reconstruction and reestablishment of pulmonary blood flow, or a hybrid procedure with a PDA stent. Finally, the question that comes up of whether you do a palliation or you do a full repair, for example, in a patient with tetralogy of Fallot. The debate centers around that shunts and bands are hard to get right, particularly in the smallest infants, and then you have a need for another procedure. And a full repair is not necessarily more dangerous, both in single-center studies and multi-center studies suggest that a full repair is as efficacious as a palliation and then repair. With that, I'll close my talk. My summary statements are prematurity and low birth weight are very important risk factors in babies with congenital brain heart disease. 39 is always better than 37, and both are better than anything less. Early versus late surgical intervention remains a revolving question, and intervention needs to be tailored to the individual heart disease and the patient. I did not really discuss all of the other risk factors and non-cardiac risk factors that we often see in these patients, including congenital diaphragmatic hernia, GI anomalies, and congenital syndromes such as Down syndrome or DeGeorge. With that, I thank the organizers for inviting me to speak today.
Thank you very much, Dr. John, for very thought-provoking presentation. Really very nice. And it must have generated a lot of questions. Inshallah, we will have a discussion at the question sessions. Our next speaker is Dr. Billy Short. She is Professor of Pediatrics, George Washington University School of Medicine and Health Sciences. She is Chief Division of Neonatology, Children's National Hospital, Washington. She is a Professor of Pediatrics at George Washington University School of Medicine and Chief of Neonatology. She joined the staff of Children's National Hospital about 40 years back, and after completing her pediatric training from University of Oklahoma and her neonatology subspecialty training at Children's National. She joined with two of her colleagues extracorporeal life support program at Children's National. Children's National ECMO program was the first to be developed at a major children's hospitals. In her recognition of this work, she was honored as an inaugural fellow of the Extracorporeal Life Support Organization. She has been a member of the founding steering committee for ELSO organization, has been president in 94-95, She's a member of the board of directors for the Children's Hospital Neonatal Consortium that has established one of the largest quality outcome database for complex patient cared for in an ICU based at Children's Hospital. The quality outcome programs within the CHNC have changed outcomes significantly for the high-risk patient taken care of in Children's Hospital and ICUs across the country. Our research and clinical work is represented by over 180 articles and book chapters in the field of neonatal perinatal medicines. Today, she is going to give us talk on update on extracorporeal life support with a focus on neonatal pediatric cases. Over to you, Dr. Billy, please.
I'd like to thank the planning committee for inviting me to talk about a subject that's very dear to my heart. I'm going to be talking about extracorporeal life support and really focusing on the neonate and the pediatric, although I will be saying a few words about adult extracorporeal life support. I have no financial disclosures. And again, this talk will be focused on the use of an extracorporeal system. This is just a schematic of a newborn on a veno-arterial ECMO, where again we drain blood from the right heart into a pumping system. This blood is then pushed through an artificial lung and returned in the baby through the arterial system where they can get bypass support for both the heart and the lung. So in my talk, I want to go a little bit through the history there, just to show you where we are today and what we've learned from our past, and also the populations that are being treated today and their outcomes, and some of the equipment changes, and then what the future holds for extracorporeal life support. A little bit about terminology. ECMO is a word used to talk about extracorporeal support when you have an oxygenator in line, a membrane oxygenator. So it's a typical term that's used very often. But if you're going to be using it for other supports that are either cardiac or respiratory, you probably want to use extracorporeal life support, and this includes ventricular assist devices like the Berlin heart. It does include ECMO, and I'll at the end talk a little bit about ECMO without a pumping system, but just with a membrane. The other terminology you will see in the literature is ECPR, and this is the use of ECMO for a patient who's coding. And in our unit here at Children's in Washington, this is primarily used in the cardiac unit for post-op cardiacs who go into acute pulmonary hypertension crisis. They can be placed on the circuit very quickly. It's a modified circuit design, so the setup is actually these units are already set up and ready to go. The surgeon just needs to place the catheters. Pumpless ECMO is now in the adult arena, and I'll talk about it at the end. This is capable of not using a pump in line, but just the membrane in line, and I'll show you how that's done at the end of this talk. But it is potentially something that can be used in smaller patients with the membranes that we have now that are very, very low resistant membranes, so you can go through an artery and a vein, just similar to some of the renal dialysis work, and oxygenate with these systems. I think you'll see these being developed more in the next few years. A word of the history. This is the first, really, in the United States, extracorporeal life support survivor. And this is the membrane lung down here, very large one. very different than today. This gentleman was in a car accident, actually had a ruptured spleen and went into ARDS, into respiratory failure. And but he really, having this success, there were several programs around the country that started treating some adults with some good outcomes. And when in the 1970 era, when the swine flu hit, there was enough cases of this ECMO being used in adults for the National Institutes of Health in the United States to fund a randomized controlled trial of ECLS versus mechanical ventilation, hoping that this would improve outcome during this flu epidemic. Interesting, during that time, that President Ford did issue nationwide vaccinations, which is a controversy in many places. This study, unfortunately, did not show an improved outcome within the adult population, but had many study design, I think, that really did not allow it to have a good outcome. The 9 centers in the study, only 3 had ever done ECMO before, so you're putting the most complicated patients on a system that, with a team that really had not trained on it. They also stopped ECMO very early. As you can see, most of these patients came off within the first week, and most of them died, unfortunately. And as we know today, with many studies now showing improved survival in the adult population, that they need to be on a minimum of 2 to 3 in some of these weeks, but some of these patients are on 2 to 3 months before they see improvement in lungs. So this study really didn't answer that question. Unfortunately, it stopped some of the research in the adult population because of the outcome of this, but it is now very routinely used in adults. And actually, with the COVID pandemic across the world right now, this is the Extracorporeal Life organization, which most ECMO programs belong to and put their data into, has a ongoing count on the COVID patients. You can go on their website; it's actually available even if you're not a member to see this. This was this Monday. There were close to 10,000 COVID patients that had gone on to ECMO, with about a 48% survival rate across the world. And so it is being used. It is a limited commodity because it takes a lot of people to run an ECMO circuit and a lot of equipment, so it's not available everywhere. But when it is available, it is being used on the COVID patients. Just again, a quick advertisement about ECMO centers. This is from the ELSA database, and the number of centers around the world are pretty extensive. The other arm, because I'm a neonatologist, was the use in the early 60s, trying to use a artificial membrane. This is a silicone membrane on premature babies to try to replicate the placenta. And this was done actually in our hospital by Dr. Avery at the time. They were using the umbilical vessels and going arterial venous, and actually didn't have a pump. They could oxygenate, remove CO2, but unfortunately the heparinization, coagulation problems, and these preemies caused all of them to have major intraventricular hemorrhages. So the really attempt to use it as an artificial placenta at this time was stopped. And fortunate for us, Dr. Bartlett, who's we consider as the father of extracorporeal life support, who had trained in Boston when they were developing many of these systems, and then moved to California, and actually was setting up the adult program for that NIH trial when he talked his neonatologist into treating this baby who had meconium aspiration syndrome. And when I looked, he wrote up this case recently to remind us her oxygen level was 20 when she went on this circuit, and obviously made it off. And what really turned the whole field around, showing that if you treat the right patient population, you actually can have a very good outcome. He published a paper with 40 children after that, mainly meconium aspirations, who had a 70% survival with predicted survival of 20%. This little girl was named Esperanza. And this is she. We had a large conference in Ann Arbor in 2019, and this is Dr. Bartlett, who's still very active doing research. He's not doing surgery anymore, but doing research and extracorporeal support, and actually designing systems that can be worn like the artificial heart. These will be artificial lungs that people can clip on and walk around. That's where his research is going, and we'll see hopefully some of that in the future. And Esperanza is doing quite well, and a lot is talking about how she survived. When you look at the ELSO data, and this is up to December of 2020, and today I looked at the number. We have 167,000 patients in the registry. The neonatal population is divided the way they look at data. In our respiratory kids, about a 70% survival to home. This used to be higher. It used to be around 80%, but we now have many new therapies that are keeping the less sick kids off of ECMO, and so the ones going on tend to be sicker. Our cardiac patients sit around 50%. And again, you've just seen two outstanding presentations on the complexity of congenital heart disease, and not just lung problems, but the repair types and reason. And I'll let John comment on that in the discussion phase. ECPR, again, in most places, this tends to be the cardiac patients who have usually post-operatively a pulmonary hypertension crisis and need to go on ECMO and other reasons. So the pediatric population, again, to home, about 67% survival, cardiac a little bit higher, and ECPR around 43%. The adults are, again, sitting about like our pediatric kids, about a 60%, a little lower than the neonatal respiratory patients. And the change over time is quite interesting. This light blue is the neonatal respiratory cases that used to be the big patients going on ECMO. This has changed, and now we look, the adult pulmonary patients are really taking over. And if you look down at 2020, the change in adult respiratory is all due to COVID. The significant increase with COVID population across the world. The pandemic is a big effect on this. The neonatal cases have dropped dramatically, and this is due to changes in the treatment. We now have surfactant. We used to, early on, had 34 to 36 weekers that would need to go on ECMO, and now we can keep them off if they have a degree of surfactant deficiency, high frequency ventilation, and nitric oxide, again, a big player in keeping our newborn kids off of ECMO. So there's pretty big changes in the populations. So if you take away the adults, this is the pediatric and neonatal, both respiratory and cardiac patients. And the pediatric respiratory have stayed pretty stable, while the neonatal is decreasing. At our institution, we do a little over 50 patients, and 60-some% are cardiac. Again, we've dropped. This used to be the opposite. If you about 15 years ago, you would see this being neonatal or cardiac and pediatric, but this is, again, due to treatments that we have available for neonatal respiratory disease. The registry, again, has great data. The neonatal respiratory cases are sitting in around 800 a year now in the registry, where, again, they used to be around 2,000. So that's an interesting change. And the type of newborns going on, respiratory newborns going on, are, again, has changed over time. The light blue down here is the diaphragmatic hernia, which has stayed pretty stable. Meconium aspiration, again, has decreased because of nitric oxide, and I think is the main factor. And pulmonary hypertension also decreased because of nitric oxide. Then we have this big other group. When you look at survival, and the other group again is a large number now. These are very complex kids that have other diagnoses. This is like the hypoxic ischemic brain injury kids that develop pulmonary hypertension, and some of the pulmonary atresias, different kids that don't fit the regular diagnostic categories. The diaphragmatic hernias now are one of the major numbers. They still sit around 56% survival. That really has stayed in the 50 to 60%. The diaphragmatic hernias that do not go on ECMO, you have, of course, almost a 90% survival. So if you look at an institution's diaphragmatic hernia survival, it will usually range around 70%. But if they go on ECMO, it's about 50 to 60%. Meconium aspirations, the best outcome. They do very well. The ones that don't make it are not due to respiratory failure, but usually due to a neurologic complication. They've usually had severe hypoxia before going on and can develop brain hemorrhages. The same with the pulmonary hypertension. These kids, again, you can reverse their lung disease, but if they have a neurologic problem, those are the ones that don't make it. And sepsis and pneumonia are, again, less and less patients for us. The pediatric group, again, you have these diagnostic categories, and then there's a large group that don't quite fit these categories, but the viral pneumonias, about a 60% survival, bacterial about the same, and ARDS, these are a little different category of respiratory failure, not secondary to pneumonias, and about a 60% survival in these kids. Equipment changes. The equipment looks very daunting, but it's really changed a lot. This is some of the older equipment with a whole ECMO system here, and the Prisma, which is a dialysis equipment you can hook in and do dialysis in, and cardiac support. This little baby up here is actually a post-op cardiac patient who's needing both cardiac support and renal support. But there's two pumping systems that people have to choose from. There is a roller pump, which many centers use, and then there's the centrifugal pumping systems. The roller pump has potential, which it's these rollers that go around and push blood out, of having some complications. If you obstruct the outflow catheter, which is the arterial catheter going back into the patient, you can actually blow the circuit up. And this is a picture of that, a patient at our institution that was being moved to get an x-ray, and the arterial catheter was kinked, and it blew the circuit up. The team is trained very quickly. We're able to get this patient back on ECMO. It took longer to clean up the wall. So that's why many people went to the centrifugal pumping systems, which had impeller blades that rotate. They will not be, if the occlusion that happens on the outflow, they do not build up enough pressure to blow the circuit up. They will just stop rotating. And they have been used in cardiac surgery for many, many years. And ECMO just really recently, or not recently, but in the last 10 years, converted over to centrifugal pumps. There's a lot of centers, though, because you have more hemolysis and a little more clotting problems with the centrifugal pump for babies, have gone back to the roller pump for babies and stay with the centrifugal for bigger kids. These are the systems available in the United States, and I think also worldwide. There are various different designs of these centrifugal pumps for using the Spectrum in our institution. And the problem is all of these pumping systems were designed for adults, and it's hard to get a company to really design for a neonatus. As you saw, it was only 800 cases a year in the neonate group. So when they design these, they're designed to flow at 2 liters and on up, where our babies are flowing around 500 and down to, when we idle, we're about 80 cc's of flow. So we're way down here. You can see the hemolysis increases with decreased flow rates. Works very well in bigger kids with decreased hemolysis. But the baby end of it is a little bit of a higher risk, and that's why some centers went back to roller pumps for their infants and then used the impeller pumps for their older kids. We have had fairly significant success with our coagulation management in using our centrifugal pumps. So we've stayed with this pumping system that we have presently. Membranes, the cardiac surgeons and the perfusionists have used this type of membranes for many, many years. These are hollow fibers with small little holes that have very good gas exchange for the time that surgery happens. But if you use it long range for ECMO, which is days, then these little holes, the albumin starts coming out of the plasma. And this is just one we tried to do on ECMO because of the heparin bonded system. So we really didn't get a good membrane until these polymethylpentane hollow fibers that don't have those small holes. They're just a very material that transmits gas exchange back and forth very effectively. And these are now used routinely across, I think, the world. And there are some other membranes that are available in Europe and especially in Japan has some very nice smaller membranes. These are the ones we have available in the United States, the Quadrox, both an adult size and a pediatric size. And the Meadows highlight, I think, has been used in Europe extensively, and it comes in 4 different sizes. The nice thing about this low resistant membrane and a centrifugal pump, it's great for transport. You can make it into a very small system to transport patients. And our hospital does have a transport team who've picked up cardiac patients that were, as Dr. D'Onofrio said, born but weren't diagnosed prenatally and needed acute placement on ECMO and transported to our institution. This is our present setup. And again, this is the pumping system right here, the centrifugal pump. And this is the membrane. This is the adult size membrane. A water bath that actually warms. You want to put the blood back at warm temperatures. And then a controlling system that actually controls the pump. And the one we have has a lot of functionality with our medical record system, so you can keep different labs and everything in this system. This is a patient being placed on ECMO on this side. This is the pediatric membrane on this system. And again, this is the spectrum pump that we use. Actually, blood is coming from this direction down through the pump, through the membrane, and then back to the patient. And just another picture of the system and what it looks like. This particular company has both a centrifugal pump and actually has a roller pump. So there is an option if you want to use a roller pump with this system. And the controller panel is really a big computer that helps monitor the pump flow, the pump pressures, but also you can download from your medical record. From your electronic medical record into here and keep many of your labs and things and correlate some of the changes in labs and flow. So a quick review of these low resistant membranes, and this is the use without a pump, mainly in adults right now, and using an arterial catheter and a venous catheter, so AV, ECMO, and it's being placed in the femoral artery and vein. So you don't need a pumping system. You can actually put these patients on fairly early. There is a nice paper that just came out with COVID patients being put on this system instead of being placed on the ventilator, and they had a tremendous improvement in outcomes. So this is some of the direction I think will be happening over the next few years. I think early intervention, not waiting for these patients to be almost meeting death criteria, but putting them on early, decreasing ventilator damage and going there. This is the Berlin heart with the lung. Just the paper on that I thought was quite interesting. And the bridge to transplant now. This is, again, some of the low-resistant membranes, and this patient is on PA in LA circulation system. And what the adults are doing, our adult program over at George Washington University is very active in this. They place these patients in an AV system, and then they get them up and walking around the hospital. They found that this is much more efficient than having them in bed and having them on high sedation. They want them up and walking around. And then these are bridging to lung transplant, these patients. Just another example of how you can do this. In the Swedish group, for many, many years, have kept their pediatric patients totally awake on ECMO and feel like they have better outcome by not having heavy sedation. What about we neonatologists? We can put this nice low, this membrane in line and create a placenta again. All of that stopped, obviously, back in the 60s when they had tremendous bleeding problems. Now we have really modified how we do our coagulation. So this is something that's coming up again. This is Dr. Kolabo, who designed the first membrane lung. And Paul did research trying to recreate this placenta back then in the lambs. They could do it, but they had a lot of complications, so this research didn't go far. But it is now back. Again, this is the 1960 work that again didn't have the best outcome. But we have two centers in the United States that are doing artificial placenta research again and having in animal models fairly good success. And this is the University of Michigan, and Dr. Michalewski has a lamb model of ECMO, so delivering these lambs prematurely, putting them on an ECMO system and supporting them, and has ended up going to a VV ECMO support from a VA. This was his original model with the umbilical vessels, but he did find that it created a fairly large shunt that the blood pressure was a problem in the lamb. Now he goes VV through a neck cannulation for these lambs. This is his setup. He shared these slides with me. The group at CHOP in Philadelphia, Dr. Flake, has very extensive research in this area and is using the umbilical vessels for his system, and has really taken this quite a ways down the road, and has companies interested in potentially making this a commercial product in the next several years. So I think we neonatologists, you may see some of these systems in the delivery room for premature babies, just placing them on a system. It still needs a lot of work, but this is where we're going. And just a word, they do grow up and do well. This guy right here, actually not a little guy anymore, but he's works on Capitol Hill, and he was a meconium aspiration patient. And she is now a pediatric hospitalist, trained, finished her medical school. She was a diaphragmatic hernia patient. This guy, I just put this in to show you, the scar can be revised by plastic surgery if the patient so desires, but he's now a lawyer and doing quite well. So I'm going to end and just invite you all. We do have our conference, which is an ECMO meeting that we have put on for several years, and it's going to be both in person, we hope, if COVID behaves, in February, also virtual, so you can sign up for either virtual or come and ski with us in Colorado. I'll end with that.
For these very thought-provoking presentations. I really find cardiology always fascinating. It might be its challenging nature. So we haven't got too many questions to ask. Actually, hasn't come up from the attendees, but really we have quite a few questions to ask from the other speakers. So the first question is to Dr. Mary. Hello.
I'm here.
Okay. Yes. Well, coming to these antenatal diagnoses, well, obviously your system is much ahead of us in terms of providing these invasive cardiology services in the neonatal unit, and even you thinking about getting these stuff into the labor ward. But what's your percentage of antenatal diagnoses, especially the critical congenital heart diseases?
That's a good question, and it varies across the United States. Looking at a study that came out of the STS database, which is really those kids with congenital heart disease that need surgery in the first month of life. So it's the important heart defect. The overall detection rate was somewhere around 30 or 40%. And it definitely gets better every year, but it still is a challenge. And there was a lot of variability depending on what part of the country you were in. In our region, it was actually at the highest at about 40%, which is unsettling to me because my goal is 100% prenatal diagnosis.
Yeah.
My partners recently led an initiative with what we call the Fetal Heart Society, which is an international research organization that I'm currently the president of, but it creates an infrastructure for studying fetal cardiology. And what we found was that when looking at, for example, hypoplastic left heart, the detection rate was nearly 100%. So we're good with those complex single ventricles, but for transposition of the great arteries, it was less, somewhere around 60%, and definitely had some variability. Socioeconomic status, ethnicity were all barriers to diagnosis. So I guess in summary, the heart defects in which the four-chamber view is normal are the ones that we're going to miss. And so that's transposition. And then the single ventricles are much more often detected. And what I mean is we're going to mean whoever's doing the screening. So once you make it to a cardiologist, we're 100%. We can really see the details of the diagnosis. Our challenge is working with the obstetricians and the radiologists who do the screening. And so there's lots of initiatives to improve detection. So I would say currently this is one of our goals in our current unit. I would say about 60 or 70% are prenatally diagnosed.
But I think that's one issue. But how do you deal with these undiagnosed surprise coming in a smaller unit? I'm asking because of the way that we have the setup and the way we are trying to manage these things. How you manage, because you always have a big setup most of the time. Cardiologists are available in a bigger unit. How you manage these things in a smaller unit? If what kind of skill level your radiologist involved in antenatal scan, what kind of skill level they have, so and how you deal with these such issues in the peripheral area.
Right. And I think I'll start the conversation, but this is certainly something that Billy and John can jump in on. You know, as I said, our goal is to work with the obstetricians for 100% diagnosis. Obviously, we're not there yet. So first thing to say is when we look at congenital heart disease, the fancy things that I was talking about are just really a small number of patients. So maybe it's about 10% of those really require very specialized care in the delivery room. The majority, if congenital heart disease is suspected, the ductus doesn't close right away. And so, typically you can get some sort of line in. Most hospitals now have prostaglandin. But that certainly is a problem in some of the very remote hospitals that prostaglandin isn't even present. The reassuring thing is that it the duct doesn't close for at least a day. So if you suspect congenital heart disease, you should initiate transfer as quickly as possible. And then there's a huge percentage of these patients that are the level ones, which, they slowly get sick over time. So I think our initiative is really, first off, to just make people aware that it should be in the differential diagnosis. We have something called pulse oximetry screening in the United States, which means that within the first 24 to 48 hours, an upper and lower extremity pulse ox needs to be obtained on every single newborn, which can certainly identify patients with congenital heart disease. And then that sort of initiates a process to figure out why this kid's newborn oxygenation isn't normal. We created the protocols that I reported at the end. That paper, the supplements to that paper include all of our, protocols for these high-risk disease. And the reason we did that was for those patients who don't make it to us to deliver, where I can be in the delivery room, can I give the neonatologist something to do, a process to hang on to that we would do? And so how I started that was I asked John, if you were standing in the delivery room, Dr. Berger, what would you do to stabilize the circulation? And then that started that flow diagram or that list of do this, this, and this. And then I gave it to Billy's partners and said, okay, well, this is what the cardiology intensivist would do. How is, in your mind, does that work for the neonatologist? And so working as a team, we were at least able to get some guidelines. So I guess the answer is you definitely need suspicion. Pulse oximetry screening has really helped us identify patients before the ductus closes in most instances. And for these really sick kids, these flow protocols, diagrams that I think help at least get some of these kids to us without extreme brain injury. I don't know, Billy and John, do you want to add to that?
Thank you very much.
I'll just jump in and then I'll let John. But I think
Mary,
we get babies transferred from 40 different hospitals, so we'll get the call, and from these very small hospitals, we haven't had, I think, the same ability to get good ultrasound diagnosis. So the kid will come out undiagnosed for anything, actually, and have to a 40, 40, 40, 40, despite what they do. If they intubate, it's 40. So that's a typical cardiac patient, but we also have found that a great percentage of those are idiopathic pulmonary hypertension. So our Mary has worked extensively, and John, with our transport team, so they will be prepared to take prostaglandins with them for that type patient. We tend to still, if it's not totally clear, bring the kids to the NICU, get the echo. If it's heart echo, they can get transferred to our cardiac unit. But I think it's the teamwork that's made that possible, and it's our team. Mary trains our transport nurses, and John also in management of these kids, so they're prepared. And thinking about it, I think that's what Mary's point was. You have to always think about it as a possible diagnosis for a kid who comes out looking like a potential respiratory kid. All right, John.
I just wanted to ask other questions. Where being a neonatologist and not asking about the PDA, this is the problem which we come across in our neonatal intensive care units. And you being a chief for neonatology, I expect that you have been dealing with these issues more frequently than others, your colleague. One issue about the PDA management is that we don't know the natural history, especially in our preterm babies. And sometimes my initial feeling was there was a time when we were trying to close it as early as possible, even prophylaxis, and then moved away from this approach. And now if patient has got a significant PDA or a stuck on a mechanical ventilation, then we treat it. Otherwise, if they are staying on the non-invasive ventilation, there's no rush to. But we are coming across in a situations where, yes, patient has got a PDA which is significant on even echocardiogram, but patient is extubated, stable on nasal CPAP, what we are going to get out of it. But we come across in a situation in that kind of patient that if we do not close, it might close at 30, 32 weeks. It might not close even at 35 weeks, and he's still on small amount of oxygen. And he, in setup like us, he might need closing the duct, ligating the duct before going home. He might need a surgery. So in what he could have been treated, if we look at retrospect, he could have been treated with some ibuprofen or paracetamol, then waiting for such a long time. So how long we should wait in such a situation if they have been extubated on CPAP, the duct is significant? What should we do, or what you should do? What you do in such a situation?
I'll say from the neonatology standpoint, John can talk about cardiology. I think if they still have a large and moderate PDA, even on CPAP, we recommend closing it. We do have the small piccolo catheters now to do cath lab closure, but that's size dependent. My concern, and again, we'll watch the kids for a while, and John will jump in here because we have the cardiologist usually right there by our sides doing the echo and telling us what they feel. I worry about neonatology tends to always go a little bit in the one direction and then say, okay, don't worry about a duct at all. And those kids getting discharged and not getting follow-up and then ending up in eventually a cardiac office with pulmonary hypertension and all the complications of having flow changes. So I do worry, and we do, if we're leaving, not closing one, we make sure they have cardiac follow-up, to make sure that doesn't continue open if they come off of CPAP and things and it's still there. But I'll let my two cardiologists comment on that.
I would submit that if you are requiring non-invasive support and you're not growing well, you obviously need to close it. And these babies, if you don't close it before discharge, they require fairly close cardiology follow-up. In the sense that you've already got one risk factor for pulmonary hypertension in the fact that they're born prematurely. You add in chronic lung disease, that's the second risk factor. You add in a ductus arteriosus. It's not unheard of for me to see a kid who's been discharged from the hospital and has new onset of pulmonary hypertension 2 or 3 months after discharge, and they can be quite difficult to treat. And if they don't have close cardiology follow-up, these kids may not have much of a murmur, so it won't get picked up by a general pediatrician often. So, and some of the worst adolescents with pulmonary hypertension that I've seen, or some of the adolescents with the most severe pulmonary hypertension that I've seen in my career, have been those children who've had prematurity and a long-standing ductus.
But my question is, Dr. John, there will be a time in these preterm babies when this duct can be closed with just medications, and more you delay, less likely to respond to this medical treatment. So if the patient has been extubated on CPAP, should we treat it within 2 weeks or wait for a couple of weeks? And if not responding, to give it medications and see how baby respond to it?
that is a $64,000 question. It is a great debate in the literature. I think that obviously prophylactic closure beyond 7 days is not indicated anymore. I don't think we know the level of support that you should close it around. And this is really a neonatology question. More than a cardiology one at that age. I think that if you're seeing any signs of pulmonary hypertension with right to left ductal shunting or low velocity left to right shunting, then I think that's probably an indication to go ahead and get it closed earlier rather than later, regardless of the level of ventilatory support. And then, of course, if there's issues with growth, again, that's another indication for early therapy. I think for the other thing that's going to play into this, the risk of, people are more hesitant in this day and age to ligate a ductus surgically because we now understand that there's a significant risk of respiratory morbidity or airway morbidity. About 30% of patients will have vocal cord paralysis after ductal ligation with a premature infant. Where the cardiac catheterization-based intervention plays into this, I think it's going to make it a bit easier to close ductuses that don't respond to therapy that we might not otherwise close with surgery. And certainly the Piccolo device that Billy mentioned is sort of ideally placed in sort of that mid-range baby who's somewhere within the 800 to 1,500 gram range, and can be done with fairly low morbidity risk in experienced hands. So,
I think the gut perfusion and the weight gain is a big deal, and if it's still moderate to large, within my group, there's some early people that jump on board and some later, and I tend to be a little bit more early because I do feel it affects gut perfusion when you're trying to get feedings up and get these kids going. So I prefer to try to treat it. We now, again, with the Piccolo device, it's easier actually to say, well, let's just go ahead and close it because it's a cath lab procedure. We will use, indomethacin or ibuprofen to try to see if we can close it, and it's, variable. And but I do worry about the perfusion of the intestinal tract.
Dr. Billy, I have recently come across these kind of cases where when a patient having a duct and then they have got an ASD as well, then they are more likely to develop chronic lung disease depending on the ASD size and the duct size. So how we should deal with such a situation, in how big the ASD should be to allow us to expect that it will not cause a hemodynamic disturbance and we can wait, or how early we should close the duct in such a situation, having a PDA and a moderate size ASD or a PFO.
Yeah, the ASD I'm going to punt to my cardiologist because they will really determine, whether that needs to have any kind of a closure or anything. Most of those kids don't. In my experience, it's more the PDA that we have significant shunting to worry about. And I don't know, John. We usually, you'll get back. There's a PFO or a PD or an ASD. But we haven't had a lot of kids that we felt that's so significant that they need early closure.
I think there's two questions. I think you're asking two separate questions here. So the first question is, if you have a moderate or large ASD, is that another indication to go ahead and prophylactically or consider early treatment with medication to close a duct? And I would submit probably yes. Although I don't think there's a ton of literature that specifically asks that sort of question. That said, a lot of the moderate ductus or moderate ASDs will get smaller fairly quickly in the premature infant. So you might get away with it. I think the other question is, if you have a child with established bronchopulmonary dysplasia and moderate to large ASD plus minus pulmonary hypertension, do you go ahead and close that ASD surgically, which is really the only way you can do it in somebody less than about 10 kilos. And the answer to that question is probably yes. If you've got somebody with established BPD, and the literature suggests that if your shunt's anywhere above excessive pulmonary blood flow, 1.5 times systemic blood flow, QPQS ratio of 1.5 to 1, you're likely to benefit from ASD closure. And there are papers, and certainly if I see a patient with a moderate to large ASD who's sort of heading down the path towards tracheostomy for severe PPD, we will often perform ASD closure, which resolves an element of pulmonary edema that the patients experience, and they can avoid a long tracheostomy. I think that's one of the important things. And if they have pulmonary hypertension, you might often see resolution or improvement in the pulmonary hypertension after ASD closure.
One more question. I know it's almost closing time now for this conference for today, but we do get patients with trisomy 21, and they do get congenital heart disease, especially complete AV septal defect. At what age you expect them to refer to cardiologists, or at cardiologists, at what age they want to see such patients in your setup? We usually hear, our UAE, they usually ask them, the cardiologists ask them to send us at 4 to 6 weeks. But recently I have come across a patient, trisomy 21, having quite a big AV septal defect, but he has got a population as well. And it is documented, reported cases that Downs maybe do get along with that sometimes, not very common. So at what age they should be seen by, how early they should be seen by the cardiologist once they are born?
I mean,
or what do you expect? Yeah, please.
Yeah, I think it's a tough question because it depends is the answer. I mean, even when we know that there's a prenatal diagnosis of trisomy 21, it's interesting. Even if we think the heart is normal on fetal ultrasound, we will see them post-delivery because there's some smaller defects that kids with trisomy 21 can have, like an ASD, for example, that sometimes is hard to diagnose prenatally. So when you kind of look at the trisomy 21 group, about half of them have congenital heart disease. And of those, half have an AV septal defect. The other half have something else, whether it's a big VSD or an ASD or a ductus. I think it's important first to get them in so you know what their diagnosis is. And then you can plan the follow-up and the management, which would include surgery. The AV septal defects also are a variability to them. We talk about the valve being balanced over both ventricles. So if it's balanced, then you would expect symptoms of congestive heart failure maybe at 4 to 6 weeks of age. Sometimes the transition with the drop in PVR is a little bit longer, so maybe 2 to 3 months of age before you start to see symptoms. But the ones in which there's unbalance and ones that also can have arch obstruction or at least a small aortic arch, they're going to develop symptoms much sooner than that. So we've had patients that develop symptoms in the first couple weeks of life because all that blood is just dumping into the right side. And then the left side has some degree of obstruction, whether it's a true coarctation or just a small isthmus. I would say as a cardiologist, for just even the straightforward AV septal defect, if I don't see symptoms, I get more worried because that means you have persistence of pulmonary hypertension. And there is data, John knows better than me, the cutoff, but certainly the trisomy 21 kids are more likely to develop pulmonary vascular disease sooner than the kid without trisomy 21 and a big hole in the heart. So usual is to try to manage them medically if they're in congestive heart failure, and then we refer them to surgery around 3 to 4 months of age. Sometimes they have to go sooner if they just have overwhelming symptoms. But the ones that don't develop symptoms are really the ones we worry about.
But what I'm asking is we do not get 100% trisomy 13 antenatally diagnosed. Most of our trisomy 13 are postnatally diagnosed. We do get.
Are you talking about 13 or 21?
Sorry, I got confused. 21. I'm talking about
21, yeah.
21.
So,
Yeah.
I mean, I think the same applies, right? So if you see
Yeah.
them in the nursery and it's a surprise diagnosis, we would do a cardiology consultation before they left the hospital.
Right.
And
Okay.
if they
That's what
didn't, and if that wasn't possible, the referral to a cardiologist should be sometime within the first couple of weeks, just because of the variability I just mentioned.
Right. Okay. Well, thank you very much. One last question to Dr. Billy. I hope my colleague organizer don't mind it. Dr. Billy, so you do deal newborns with on ECMO. We don't see many patients for ECMO, but sometimes patients with congenital diaphragmatic hernia or meconium aspiration syndromes, we have to refer them, or with pulmonary hypertensions. So at what point you want us, you expect neonatologists to refer this patient for the ECMO? I understand, yes, you have got ECMO in your own system, so you have a different kind of setup. But we have ECMO only in one center in let's say in Abu Dhabi Emirates. So at what point is it the oxygen index you take the criteria, or how you expect our neonatologist team at what stage we should refer? And the second thing is, what about their neurodevelopmental outcome? How you see this thing?
Yeah, that's an outstanding question because that's what we deal with all the time. And I think what I recommend, most people use this oxygen index as an indicator for needing ECMO, and 40 is kind of the number that if they persistently are at 40, then they would be better to go on to ECMO. What I tell a referring hospital is you can't wait till it's 40, because then we have to put them in an ambulance and transport them. So you need a conversation with your ECMO center if your OI gets close to 30, which is, again, a kid on 100%, and the mean airway pressure, may still be low, but I think just a conversation helps, because what we do is we say, yeah, that kid's really starting, to go the wrong direction. Let's get him here first. And we have about half the kids that come don't go on ECMO, and it's better to do that and then get them back to the referral center once they're stable, than to have them coming in. We have one particular center I won't mention, but they'll be on nitric, on an oscillator, and a PO2 of 20 when they call us. And that's a kid. It's very dangerous to try to transport that type of patient. You've been able to do it, but that's the kid that will have the surgeon standing at the doorway when we get the kid in. So I think conversations, if you've got a good relationship with an ECMO center, once you're on 100%, once you're on maxed out, and what you consider maxed out ventilation, and most places now do have nitric, you need to call and say, well, the PO2's now been 100, but if they start falling, down into the, most centers will call when the PO2s are like the 60 range on the maxed out ventilation so we can get into this. So it's not a totally good answer, but that's what I think. Conversations and getting them in earlier is actually safer than waiting really late. I forgot what your other question was.
The neurodevelopmental outcome in patients when you put them on ECMO, especially the meconium aspiration syndrome. I know you don't put CDH, and what about PPH and patient as well?
Actually, most of the patients now are CDHs because we're keeping most of the meconiums off, although there's a handful that go on. It's actually pretty good. The thing you have to watch, we had a nice study, but this was early in ECMO, and we're actually doing a lot safer with ECMO now, but 70% of the kids actually neurodevelopmentally look normal. You have to watch stool age. What we found is at 5 years, even though they were looking good at 2 years, which is where NIA, at least our Institute of Health, stops, won't pay you to go beyond that, but we were able to get a 5-year study. About 40% were testing that they might need special schooling and more of a school issue, not having major, developmental or neuromuscular issues, but having learning disabilities when they went to school. So they need to be followed closely. It's interesting, there's only one adult paper that was a questionnaire sent out. And the thing I worried about, and my cardiologist colleagues down there, is especially the idiopathic pulmonary hypertension. Are they going to be the adults who then develop pulmonary hypertension or develop it as an adult? And so far, it does not appear, but no one knows because they're just getting into the 20 to 25-year age now. So it's still not determined, but something to worry about.
Okay, well, thank you very much, Dr. Billy, Dr. Mary, and Dr. John, for sharing your unique and very important experience for us. It will guide us in our clinical practice.
Right.
And thanks again. So with this much, I will close the meeting today. Okay, thank you very much.
Thanks for having us.
Thank you.
So what an incredible day has gone by, and now we are closing the second day of this 11th International Neonatology Conference. I thank you once again to our panel of speakers who presented today, and I hope our audience gain new knowledge, perspective, and idea that they can apply in their field of practice. Also, ladies and gentlemen, this event will not be possible without the participation and support of the following organizations. And they are the Children's National Hospital, USA, Children's Hospital of Philadelphia, USA, Chai Pharmaceuticals, Sobi Pharma, Roche, and Prolecta. On behalf of MENA Conference, this is your superstar host, Vincent, wishing you all a lovely evening, and thank you and good night.
Oh, our superstar.